Your thyroid is normal, but you feel terrible? Here is why. I want to tell you about a number that may be quietly running your life right now, and that your doctor is probably interpreting incorrectly. It is called TSH, thyroid stimulating hormone. It is the primary blood test used to assess thyroid function in virtually every primary care office in America. And the reference range that most laboratories use to determine whether your result is normal, the range that determines whether your doctor tells you your thyroid is fine, was established using data from a population that included a significant percentage of people who already had undiagnosed thyroid disease. In other words, the normal range was calibrated against an abnormal population, which means that millions of Americans, disproportionately women, disproportionately over 50, are being told their thyroid is functioning normally when, by a more precise standard, it is not. The thyroid is a small butterfly-shaped gland that sits at the base of your throat. It weighs less than an ounce, and it produces hormones that regulate the metabolic rate of virtually every cell in your body: your heart rate, your body temperature, your brain function, your digestive speed, your muscle strength, your cholesterol levels, your mood, your hair, your skin, your energy, and your body weight. When it is working correctly, you may not notice it at all. When it is working suboptimally, even subtly, even within the technical boundaries of the normal range, the effects permeate everything. After 50, thyroid dysfunction becomes dramatically more common. Studies suggest that subclinical hypothyroidism, low thyroid function that does not yet trigger a formal diagnosis, affects between 15 and 20% of women over 60. And the symptoms are so diffuse, so easily attributed to other causes, that the vast majority of those people are told they are simply aging. Today, I am going to give you the complete picture: what the thyroid actually does, why it changes after 50, what the testing tells you and what it misses, and what the current evidence says about optimizing thyroid function. We will dive into all of that in today's episode. I am Dr. Alexander Wellrich. Of all the topics I have covered in this series, thyroid health is the one that generates the most letters and messages from viewers. People who have been told their thyroid is normal, yet feel anything but, and who sense intuitively that something is being missed. In many cases, that intuition is correct. The thyroid conversation in mainstream medicine has been dominated for decades by a binary framework. Either you have clinical hypothyroidism and get treated with medication, or your TSH is in range and the thyroid is removed from the diagnostic picture. The emerging science and the clinical reality I have observed across 30 years of practice tells a more nuanced and more useful story. Understanding your thyroid is not just relevant if you have been diagnosed with a thyroid condition. It is relevant to every person over 50 who deals with unexplained fatigue, stubborn weight, brain fog, cold intolerance, mood changes, hair thinning, constipation, elevated cholesterol, or diminished motivation. These are the fingerprints of suboptimal thyroid function, and they deserve a more sophisticated response than a single TSH number and a reassurance that everything is fine. If this kind of thorough, honest medical education is valuable to you, please subscribe to this channel. And now, let us talk about the gland that may be more central to how you feel every single day than any other structure in your body. Let me start with the physiology because I want you to genuinely understand what we are talking about, not just a list of symptoms. Your thyroid gland produces two primary hormones: thyroxine, called T4, and triiodothyronine, called T3. T4 is the storage form. It is produced in larger quantities and circulates in the bloodstream until it reaches the tissues that need it. T3 is the active form, the hormone that actually enters cells and binds to receptors in the cell nucleus, where it regulates gene expression and metabolic rate. Most T3 in the body is not produced directly by the thyroid but is converted from T4 in peripheral tissues, primarily the liver, the gut, and the kidneys. This distinction between T4 and T3 is fundamental to understanding why standard thyroid testing often misses the picture. TSH measures whether your pituitary gland is signaling your thyroid to produce more hormone, not how much active T3 is actually reaching your cells. You can have adequate T4 production and suppressed TSH, yet have poor T3 conversion, meaning your cells are not receiving the thyroid signal they need. This situation, normal TSH, normal T4, low T3, is invisible on the standard TSH-only panel, but produces every symptom of hypothyroidism. Now let me give you a sense of what thyroid hormones actually do at the cellular level, because the breadth is remarkable. T3 binds to receptors in virtually every cell type in the body. In cardiac muscle cells, it regulates heart rate and contractility. In neurons, it governs brain development and cognitive function. In adipose tissue, it regulates fat metabolism and thermogenesis. In the gut, it controls peristalsis, the muscular contractions that move food through the digestive tract. In the liver, it regulates cholesterol synthesis. In hair follicles and skin cells, it controls growth and regeneration. When thyroid hormone signaling is suboptimal, even slightly suboptimal, the effects appear across all of these systems simultaneously. Heart rate slows slightly, metabolism becomes less efficient, brain function dulls at the edges, gut motility slows, producing constipation, cholesterol rises, hair thins and skin becomes dry, fat accumulates despite normal eating, energy drops persistently. These changes do not require frank clinical hypothyroidism to occur. They occur on a spectrum, and after 50, a significant portion of the population sits in a suboptimal zone that standard testing does not capture. After 50, thyroid function is affected by several converging biological changes that are worth understanding precisely, because some of them are addressable. The first is the natural aging of the thyroid gland itself. Thyroid volume decreases with age, the gland becomes more fibrous, and its hormone-producing follicles become less efficient. A study published in the European Journal of Endocrinology found that thyroid hormone production declines measurably across the adult lifespan, and that compensatory increases in TSH are common, meaning the pituitary is working harder to drive a gland that is producing less. The second is reduced T4 to T3 conversion. The enzymes responsible for converting T4 to active T3, called deiodinases, become less efficient with age, and are impaired by several factors that become more common after 50. Chronic inflammation, nutrient deficiencies, particularly selenium and zinc, chronic stress, and caloric restriction. This means that even people with adequate T4 levels may have insufficient T3 activity at the cellular level, the situation I described earlier that standard testing misses. The third is the dramatic increase in autoimmune thyroid disease after 50. Hashimoto's thyroiditis, an autoimmune condition in which the immune system attacks thyroid tissue, is the most common cause of hypothyroidism in the developed world, and its prevalence increases sharply with age. A study published in the journal Thyroid found that the prevalence of thyroid antibodies, the immune markers of Hashimoto's, was present in over 20% of women over 60. Many of these individuals have normal TSH levels and have never been diagnosed, yet their thyroid tissue is actively being damaged by their own immune system. The fourth factor is the decline in sex hormones after 50. Estrogen influences thyroid hormone-binding proteins in the bloodstream. The hormonal shifts of menopause in women create changes in how thyroid hormones are transported and delivered to tissues, which can alter the effective thyroid signal even when production remains unchanged. This partly explains why thyroid-related symptoms often intensify or become newly apparent around the time of menopause. The fifth factor, and this is one I emphasize strongly because it is entirely modifiable, is nutritional status. The thyroid requires specific micronutrients to produce hormone. Iodine and tyrosine are the raw materials of T4 and T3 themselves, Selenium is required by the deiodinase enzymes that convert T4 to T3. Zinc supports both production and receptor sensitivity. Iron is necessary for thyroid peroxidase, the primary enzyme of hormone synthesis. Vitamin D receptors are present in thyroid tissue and play a role in immune regulation relevant to autoimmune thyroid disease. Many adults over 50, particularly those on restrictive diets, have insufficient levels of one or more of these nutrients, quietly impairing thyroid function without any identifiable disease. A few years ago, I worked with a patient I will call Diane. She was 57, a former teacher from Denver, Colorado. She had been seeing her primary care physician for 3 years with a consistent set of complaints: fatigue that sleep did not resolve, weight gain of about 18 pounds over 2 years despite no change in her eating habits, hair thinning, particularly at the temples, constipation, cold hands and feet even in warm weather, and a persistent mental heaviness she described as feeling like she was thinking through wet concrete. Every year, her doctor had checked her TSH. Every year, the result had come back of 3.8, within the standard laboratory reference range of 0.5 to 4.5. Every year, she had been told her thyroid was normal. Her symptoms had been attributed to menopause, stress, and aging. When I ordered a full thyroid panel, TSH, free T4, free T3, reverse T3, and thyroid antibodies, the picture that emerged was entirely different. Her free T3 was in the lowest quartile of the reference range. Her reverse T3, a metabolically inactive form of T3 that competes with active T3 for receptor binding, was elevated, indicating impaired conversion. And her thyroid antibodies, anti-TPO, were significantly elevated, confirming subclinical Hashimoto's disease that had never been diagnosed. Diane's thyroid was not fine. It had never been fine. The standard test had simply not been looking at the right things. We addressed her conversion impairment through selenium and zinc repletion, a dietary anti-inflammatory protocol to reduce the autoimmune attack, and, after further evaluation, a low-dose T3-containing thyroid support protocol discussed with her endocrinologist. Within 4 months, Diane told me she felt like herself for the first time in 3 years. And here is where this becomes even more important for the audience watching today. Because what Diane's story illustrates is not just a medical oversight. It is a systematic gap in how thyroid disease is screened and managed in adults over 50. And understanding that gap may be the most important thing you take from today's episode. Let me give you the detailed testing picture because this is where the practical knowledge lives. The standard TSH test alone is insufficient for a complete assessment of thyroid function in adults over 50. Here is what a comprehensive thyroid panel should include, and what each component tells you. TSH, thyroid-stimulating hormone, tells you how hard the pituitary is working to drive thyroid output. A TSH above 2.5 in the context of symptoms is worth discussing with your doctor, even if it is technically within range, because a growing body of endocrinology research, including guidelines from the American Association of Clinical Endocrinologists, suggests that the optimal functional range may be between 1.0 and 2.0, not the broader laboratory range of 0.5 to 4.5. Free T4 tells you how much storage thyroid hormone is circulating. This is important but incomplete on its own, because T4 must be converted to T3 to have metabolic effect. Free T3, and I want to emphasize the word free, meaning the unbound, bioavailable fraction, tells you how much active thyroid hormone is actually available to enter your cells and drive metabolism. This is arguably the most clinically relevant number, and it is the one most commonly omitted from standard panels. A free T3 in the lower third of the reference range in the context of symptoms warrants attention. Reverse T3 is the metabolically inactive isomer of T3 that your body produces preferentially under conditions of chronic stress, inflammation, caloric restriction, or illness. Elevated reverse T3 blocks the receptors that active T3 needs, meaning high reverse T3 is a form of cellular thyroid resistance, even when other numbers look adequate. Chronic dieting, high cortisol, and systemic inflammation are the most common drivers of elevated reverse T3, and all three are more prevalent after 50. Anti-TPO and anti-thyroglobulin antibodies are the markers of autoimmune thyroid disease, Hashimoto's. Their presence confirms that the immune system is attacking thyroid tissue, even if hormone levels are currently within range. This matters because it changes the management approach, addressing the autoimmune component through dietary anti-inflammatory strategies, vitamin D optimization, selenium, and in some cases, low-dose naltrexone under medical supervision can slow the progression of glandular damage. When you see your doctor, you can ask specifically for a full thyroid panel that includes free T3, reverse T3, and thyroid antibodies in addition to the standard TSH and free T4. Some doctors will order these readily. Others may push back, citing cost or the argument that TSH alone is sufficient. If you have persistent symptoms that have not been explained, fatigue, weight, brain fog, hair loss, mood changes, constipation, cold intolerance, advocating for this panel is entirely reasonable, and I would encourage you to do so. Now let me give you the evidence-based dietary and lifestyle picture. What you can do to support thyroid function that does not require a prescription. Selenium is the single most important micronutrient for thyroid function that most people are not getting enough of. It is required by the deiodinase enzymes that convert T4 to T3, by the glutathione peroxidase system that protects the thyroid from oxidative damage, and it has a direct immunomodulatory effect relevant to Hashimoto's. A randomized controlled trial published in the Journal of Clinical Endocrinology and Metabolism found that selenium supplementation at 200 micrograms per day significantly reduced anti-TPO antibody levels in women with Hashimoto's thyroiditis. Brazil nuts are the most concentrated food source. 2 to 3 Brazil nuts per day provides the daily requirement. Other sources include tuna, salmon, turkey, and eggs. Zinc is the second critical mineral for thyroid function. It is required for TSH synthesis, T4 production, and the activity of the deiodinase enzymes. Zinc deficiency, which is relatively common in older adults, particularly those on plant-heavy diets or taking proton pump inhibitors, impairs T4 to T3 conversion. Food sources include oysters, beef, pumpkin seeds, and lentils. If supplementing, 15 to 30 milligrams of zinc picolinate or zinc glycinate is the commonly studied range. Iodine is the foundational building block of thyroid hormones. T4 contains 4 iodine molecules, T3 contains 3. Adequate iodine is essential for thyroid hormone production. However, and this is a nuance many wellness sources miss, excess iodine can be problematic, particularly in people with Hashimoto's, where it may exacerbate the autoimmune attack. Seafood, dairy products, and iodized salt are the primary dietary sources in the United States. Most Americans with a varied diet receive adequate iodine. High-dose iodine supplementation should not be undertaken without medical guidance and confirmed deficiency. Iron is essential for thyroid peroxidase, the enzyme that synthesizes thyroid hormones. Iron deficiency, even mild deficiency without frank anemia, can significantly impair thyroid hormone production. A study published in the American Journal of Clinical Nutrition found that correcting iron deficiency improved thyroid function and reduced TSH in iron-deficient women. Red meat, liver, shellfish, and legumes are the primary dietary sources. A serum ferritin test, a more sensitive marker of iron stores than hemoglobin, is worth requesting if thyroid symptoms persist. Vitamin D deserves mention because thyroid tissue contains vitamin D receptors, and vitamin D plays a direct role in immune regulation. Multiple studies have found an inverse relationship between vitamin D levels and thyroid antibody levels in Hashimoto's patients. A study published in the International Journal of Molecular Sciences found that vitamin D supplementation reduced anti-TPO antibodies in vitamin D-deficient Hashimoto's patients. Given the extraordinary prevalence of vitamin D deficiency after 50, this is a straightforward intervention to discuss with your physician. On the lifestyle side, chronic stress is one of the most powerful suppressors of T4 to T3 conversion through its elevation of cortisol and reverse T3. Everything we discussed in our inflammation and sleep episodes connects here. Stress management, adequate sleep, and reduction of chronic inflammatory load all support thyroid conversion efficiency. And vigorous caloric restriction, crash dieting, very low-calorie protocols, is a particularly potent driver of poor T3 conversion, as the body interprets starvation as a signal to reduce metabolic rate by shifting from active to inactive thyroid hormone. Sustainable, moderate caloric management is significantly better for thyroid function than aggressive restriction. Let me address Hashimoto's thyroiditis specifically, because it is extraordinarily common in adults over 50 and chronically under-discussed in standard medical care. Hashimoto's is an autoimmune condition in which the immune system produces antibodies that attack thyroid tissue, specifically the enzyme thyroid peroxidase and the protein thyroglobulin. Over time, this immune attack destroys thyroid cells, progressively reducing the gland's ability to produce hormone. It is the most common cause of hypothyroidism in the developed world, and it is diagnosed by the presence of elevated anti-TPO or anti-thyroglobulin antibodies. The conventional medical approach to Hashimoto's is largely passive. Monitor TSH and prescribe thyroid hormone replacement when TSH rises above the treatment threshold. What this approach misses is the opportunity to address the autoimmune process itself, to reduce the immune attack on the thyroid tissue, which can slow the progression of glandular damage and reduce the eventual hormone replacement requirement. The interventions with the strongest evidence for reducing Hashimoto's antibody levels include the ones we have already discussed: selenium supplementation, vitamin D optimization, and a dietary anti-inflammatory approach. A gluten-free diet has shown benefits specifically in a subset of Hashimoto's patients, particularly those with concurrent non-celiac gluten sensitivity, which appears to share immunological mechanisms with thyroid autoimmunity. A study published in Endocrine Connections found that a 6-month gluten-free diet significantly reduced anti-TPO and anti-thyroglobulin antibodies in non-celiac Hashimoto's patients. This is not a recommendation to eliminate gluten for everyone, but for people with confirmed Hashimoto's who have not responded to other interventions, a 3-month gluten-free trial under physician guidance is a reasonable and evidence-informed step. The gut microbiome, our second episode topic, also connects directly to autoimmune thyroid disease. A study published in Thyroid Research found significant differences in gut microbiome composition between Hashimoto's patients and healthy controls, with reduced diversity and lower levels of specific anti-inflammatory bacterial strains in the Hashimoto's group. Supporting gut health through the strategies we discussed, fermented foods, plant diversity, fiber, is not only beneficial for digestion and brain function, it may directly modulate the autoimmune process attacking your thyroid. Here is your action plan. A specific, science-grounded set of steps you can begin implementing immediately. 1. Request a full thyroid panel at your next appointment, not just TSH. Ask specifically for free T4, free T3, reverse T3, anti-TPO antibodies, and anti-thyroglobulin antibodies. Write these down and bring the list to your appointment. If your doctor is hesitant, explain that you have persistent symptoms: fatigue, weight, brain fog, hair loss, cold intolerance that have not been explained, and you want a complete picture. 2. Add 2 to 3 Brazil nuts to your daily diet. This is the simplest, most direct way to ensure adequate selenium intake for thyroid conversion and autoimmune modulation. Do not exceed 5 to 6 per day over the long term, as selenium toxicity is possible with excessive intake. 3. Get your vitamin D level checked and optimize it to between 50 and 70 nanograms per milliliter. Vitamin D deficiency is not just a bone health issue. It is a thyroid health issue and an immune regulation issue, with measurable effects on antibody levels in autoimmune thyroid disease. 4. Have your ferritin level checked, not just hemoglobin but ferritin specifically. Iron deficiency without anemia is common, frequently missed, and directly impairs thyroid hormone synthesis. A ferritin below 50 nanograms per milliliter is worth addressing through dietary iron or supplementation under physician guidance. 5. Address your chronic stress load with the same seriousness you address your diet. Elevated cortisol from chronic psychological stress directly suppresses T4 to T3 conversion and elevates reverse T3. The sleep protocol, the morning light, the stress management practices we have discussed throughout this series, they are thyroid interventions as much as they are sleep or inflammation interventions. 6. If you have confirmed Hashimoto's and have not yet tried a gluten-free protocol, consider a structured 3-month elimination trial under physician supervision. It is not for everyone, but the evidence supports it for a meaningful subset of autoimmune thyroid patients, and the risk is low. 7. If your free T3 is low or reverse T3 is high despite adequate TSH and T4, have a specific conversation with your physician or an endocrinologist about whether T3-containing thyroid support, either as liothyronine or a natural desiccated thyroid preparation, might be appropriate. This is a nuanced, individual clinical decision, but it is a conversation that is being increasingly supported by endocrinology literature, and one you have the right to initiate. Let me bring everything together. Your thyroid is the metabolic regulator of your entire body. After 50, it is affected by the natural aging of the gland, reduced conversion efficiency, nutrient depletion, hormonal shifts, increasing autoimmune activity, and chronic stress, all converging on a system that was already working hard to regulate every cell you have. The standard medical approach, TSH alone, treatment only when numbers cross an arbitrary threshold, leaves a significant gap between what testing shows and what people feel. Diane's story is not unusual. It is repeated in doctors' offices across America every week, in patients who are told they are normal and sent home to live with symptoms that are neither normal nor inevitable. The complete thyroid picture requires complete testing, nutritional support for the specific micronutrients the gland depends on, lifestyle management of the stress and inflammation that impair conversion, and, where autoimmune disease is present, targeted interventions to slow the immune attack itself. You are your own best advocate. The knowledge I have given you today, the testing to request, the nutrients to optimize, the conversations to initiate, gives you the tools to advocate more effectively. Use them. If today's episode was useful, please like this video, subscribe to the channel, and share it with someone whose symptoms you recognize in what I have described today. Leave me a comment. Tell me whether you have been through the experience of being told your thyroid is normal despite feeling anything but. I read every comment, and your story matters. In our next episode, we are going to talk about something that affects virtually every aspect of health after 50, and is almost never addressed directly in primary care. The dramatic shift in sex hormones, testosterone in men, and estrogen and progesterone in women, that begins in the late 40s and 50s. What the research says about the effects of that shift on the brain, heart, bones, and metabolism, and what the current evidence says about addressing it. It is a conversation I have wanted to have for a long time. Until then, take care of yourself, from the inside out.